So before we begin the talk about my research, I just want to give a quick overview of the cerebral circulation. So the cerebral circulation itself is made up of the afferent and the efferent vessels. The afferent vessels are the major source of blood bringing into the brain, and it includes what's shown here in blue as internal carotid artery and the vertebrobasilar system. And the efferent vessels distribute the blood specific to specific areas of the brain, and they include all of which is shown in red, the A1 and A2 segment of anterior cerebral artery, the anterior communicating artery, the posterior communicating artery bilaterally, and the P1 and P2 segment of the posterior cerebral artery, all shown in red here. And in traditional sense, the circle of Willis itself is made of the bilateral A1 segments of the ACA and the ACOM, which is the anterior communicating artery, and the bilateral segments of posterior communicating artery and the bilateral segments of P1 segment of the posterior cerebral artery. And all of these vessels serve to provide collateral circulation to the brain. It has been well studied in literature that the classic complete circle of Willis is only apparent in minority of cases, with majorities, meaning 60 to 70% of people showing at least one type of typical variation in the structure of circle of Willis. Additionally, these variations are shown to be highly population specific. Although most of these variations are usually incidental findings and asymptomatic, many procedures such as these, including the carotid eversion endarterectomy without shunting, anterior selective cerebral perfusion with moderate hypothermia, endovascular embolization, and microsurgical clipping, to name a few, rely on the knowledge of the circle of Willis variation to prevent serious adverse outcomes. Additionally, the degree of collateral circulation determines the extent of vascular insult. Multiple sources in literature support that these variations lead to asymmetry in the blood flow, causing changes in the hemodynamics. And these changes, in turn, could alter the histology of the vasculature and are hence a major causative factor for aneurysm and stroke. So in our study, we aim to add to the literature on the variations of circle of Willis in the Midwestern population and explore this impact of such variation on blood flow and its predisposition to atherosclerotic diseases. So to do this, we obtained the brains from 25 formalin-embalmed cadavers from the KCU Joplin campus. And the brains were dissected out under dissecting microscope to expose the circle of Willis arteries and major arteries, which are shown here marked on the brain. And photographs of the entire circle of Willis and some small cut sections of the major vessels were taken for future measurements using ImageJ software. Initial identification of the circle of Willis was recorded as either complete or incomplete based on a recent systematic review of classification system proposed by Iyer et al. And here shown are the picture of the entire complete circle. And RStudio software was used for statistical analysis, and Welch's t-test and Pearson correlation was done for statistics. In terms of detailed measurements that was taken using ImageJ, we took the length measurements for all of the bilateral A1 segment, the anterior communicating artery, bilateral P1 segment, and posterior communicating artery bilaterally. And the vessel circumference was measured for all arteries, including the A2 segment of ACA, P2 segment of BCA, middle cerebral artery, MCA, and internal carotid artery, ICA. And here shown in blue is the cut section and how we took the circumference measurement. And in terms of plaque area, it was also taken from the cut section of the artery where there was maximum stenosis, and by drawing around the area of plaque using ImageJ software. And from this, the vessel diameter and the person's stenosis was calculated mathematically using the formula shown here. And this table shows the types of variation considered for the classification and the definitions according to the Iyer et al. Classification system. I just wanted to bring your attention to one particular type of variation that we will be discussing more in detail, which is the hypoplasia, that is defined as a vessel lumen diameter less than 1 millimeter. And all the other types of variations and their definitions are provided here. So in terms of our results, out of our 25 cases, we saw variation in 23 cases, which comprised of about 92%. And out of these 23 cases, 9 cases, comprising of 36%, showed a single type of variation according to the classification system used. And those numbers are provided under each of the classified variant. And 6 cases showed a dual variation, which comprises of a combination of anterior type variation and a posterior type variation, with those classification numbers provided here as well, according to the IRL classification system. The remainder 8 cases had variation that are not included in the classification system we used. And this included a very uncommon variation of bilateral A2 duplication that resulted in a quadruplated A2 segment, which is shown here. And among the vessels that showed variation in the descending order, the percentage distribution of variation was seen in PCOM, followed by anterior communicating artery, followed by ACA, PCA, and others, including middle cerebral artery. And the PCOM, among PCOM, the variation that was predominant was hypoplasia. And there was either bilateral, comprising of about 47.1%, and unilateral, comprising of about 41.2%. And besides hypoplasias, the other type of variations we observed were duplications, triplications, fenestrations, atypical bifurcation, branching pattern, and aplasia, which are all shown here. And this is provided in the order of their existence and prevalence. In terms of stenosis, within the variants, the most stenosed vessel in the efferent wing was the MCA, comprising of about 36%. And the afferent vessel with most stenosis was seen in ICA, which was 52%. And when we plotted the percentage of variant vessel diameter and the overall stenosis here, we found a negative correlation between the variant vessel diameter in the posterior part of the circle and the overall stenosis, meaning that as the as the variant vessel diameter decreased in the posterior cerebral arteries, the overall stenosis increased. And this trend was also observed for efferent stenosis and the variant vessel diameter in the posterior cerebral arteries variants. And since posterior communicating artery was the vessel that showed most variation, so when we plotted the posterior communicating artery diameter against the overall person stenosis, we saw a similar negative correlation described previously. More interestingly, when we plotted the post-PCOM diameter, as the PCOM diameter decreased to hypoplasias and between unilateral hypoplasia and bilateral hypoplasia, we saw a significant increase in ICA stenosis percentage. So the red arrow here pointing to the bilateral PCOM hypoplasia, which had higher ICA stenosis compared to the blue graph here, blue line here, showing the unilateral PCOM hypoplasia. So from the previous studies, it has been shown that there is a higher likelihood of developing stroke, migraine, and cognitive dysfunction in case of PCOM hypoplasia, especially when these hypoplasias occurred in association with other circle of Willis anomalies. Moreover, studies also showed that there is an association between PCOM hypoplasia and stroke, and that becomes more pronounced with ICA occlusions. In our study, we found that there is an increase in ICA stenosis, especially in the case of bilateral PCOM hypoplasia compared to the unilateral subjects that was described in the graph previously. And all of this suggests that PCOM hypoplasia as a risk factor in ischemic stenosis, especially in the case of bilateral PCOM hypoplasia. This correlation between the ICA and the major efferent vessel stenosis and the variation aligns with the finding in our circle of Willis variation studies. But let us take a minute to understand why we may be seeing this association. This observed association may be caused by hemodynamic changes due to decreased diameter. For instance, when the vessel diameter decreases, it leads to an increased flow velocity. Heightened velocity leads to turbulence in the blood flow, And this causes higher shear stress on the walls of the endothelium. Shown here, the piezo-1 is a mechanosensory cell surface protein that senses the shear stress experienced on the walls of this endothelium, and it transmits the signal to initiate a cascade of events that culminates in activating a pro-inflammatory signal such as NF-kappa beta. And this sets the stage for an arthrogenic plaque formation. And in terms of the brain, this arthrogenic plaque formation could result in occlusion of the cerebral vessels, leading to generation of ischemic stroke. So even in the absence of ICA stenosis, PCOM hypoplasia has been shown to increase the likelihood of stroke. Thus, PCOM hypoplasia, especially when bilateral, could serve as a predictive marker of risk and screening tool for cerebrovascular disease, particularly stroke. So given this potential as a predictive marker, screening for bilateral PCOM hypoplasia can be achieved through non-invasive screening techniques like MRA. And here you can see the PCOM hypoplasia on one side, whereas this is a normal PCOM. And basically, you can predict this by subjecting the high-risk population to this MRA studies. And if detected early, it can help identify individuals at high risk for cerebrovascular ischemic disease, including stroke and aneurysm. Thus, integrating screening for PCOM hypoplasia into routine clinical practice could help clinicians implement preventative measures such as lifestyle modification, medication, and close monitoring of these at-risk population. One potential impact could also be at the level of public health by reducing the burden of cerebrovascular disease on healthcare systems and in our society. So our study not only adds to the literature on intracranial arterial variations, but also fills the gap in the literature on the less reported variations, some of which we think could be unique to the Midwestern population. And recognizing that there may be a population-specific risk factor for cerebrovascular disease, our study also attempts to explain how these variations in the circle of Willis may influence this incidence and severity of the disease in populations such as ours in the Midwest. However, the relative small sample size emphasizes the importance of a more robust data to strengthen the findings of our study and to generalize these results to a broader Midwestern population. And this could be achieved by doing more longitudinal studies or adding more donors and also continuing the study in the future in this area. So with that, I conclude my talk, and here are my references. And I wanted to extend my sincere thanks to all of my team, my fellow Joplin friends, Chloe, Dominic, Cameron, student Dr. Sheridan, and Dr. Marhoff, and Dr. Hillard, who's my PI for this project. And thank you so much for your guidance through this whole process. And I also wanted to thank the KCU Gift Party program, without whom we would not have been able to do this research. So thank you so much.